Uh, yeah, I'm a master's student in medical physics. My name is Nakshatra, and um, before I start, I would like to thank my supervisors, Dr. Jake and Peshman, for all the support so far, and also everyone who's listening. Um, so before I start, I would like to give an overview of what I'll be presenting today. I'll start with the background and clinical problem, and then dive into or introduce SGRT, or surface-guided radiotherapy, and how it integrates with DIBH, which is the breath hold technique. After that, I'll go into the benefits, followed by the actual proposal, which starts with the aim, methodology, study plan, and expected outcomes. So, breast cancer is one of the most common cancers globally, and the primary treatment for it is surgery. So this surgery can either be a lumpectomy, which is a breast conservation surgery where part of the breast is removed, or a mastectomy where the whole breast is surgically removed. Now, where does radiotherapy come into play? So radiotherapy in breast cancer is mainly used to destroy the residual cancer cells, and also it helps with preventing recurrence of the cancer. Now, this comes with a few added complications about addition to the radiation dose. Since because of the proximity of heart and lungs to the breast, so even small inaccuracies in patient positioning can actually increase the dose to these critical organs. Also, in breast cancer, usually hypofractionation is a very efficient method, and also it's very accessible. So hypofraction, which basically means fewer higher dose sessions, is commonly used. So additionally, in some cases, even accelerated fractionation is used. So we are dealing with a lot of dose here per session, which adds to the requirement of a higher level of accuracy because of the fractional dose. Therefore, precise patient positioning is required because in the end, the basic concept of radiotherapy is to kill the cancer cells and spare the healthy tissues. Now, the conventional methods, mainly tattoo and laser-based alignment and IGRT, image-guided radiotherapy, are still used, but they have certain limitations in terms of accuracy and patient experience. Traditionally, patient positioning for breast cancer, breast radiotherapy, starts with tattoos placed on skin. Now, these act as a fixed point that the room lasers can align to, helping the therapist to position the patient consistently each day. Another common approach and very accurate approach is IGRT, which is image-guided radiotherapy, which involves X-ray or CBCT scans to check the internal anatomy against the treatment plan. And this is a very accurate positioning method. However, both methods have important limitations as they don't provide, some of them are, they don't provide real-time feedback, which means patient motion during the treatment, especially from breathing or posture changes, isn't accounted for. And also, tattoos, while helpful, can have a lot of psychological and cosmetic impact as cancer treatment journey can be quite distressful for the patient, and they would like to not have a permanent and visual reminder of that. Another reason is breast tissue can move and deform quite a lot and relying only on bony anatomy is not reliable enough. So these limitations open door to and also, of course, the imaging tools of IGRT. So these limitations open door to a new advanced patient positioning technology like surface-guided radiotherapy, which we'll look into next. Now, surface-guided radiotherapy, or SGRT, is a non-invasive imaging technology that uses 3D optical surface imaging to track the patient's position in real time. So the system captures a live surface of the map of the patient, surface map of the patient, and compares it to a reference generated during the CT, generated from the CT or the live camera itself in the room. And the SGRT algorithm provides live feedback or displacement between these registrations in 6 degrees of freedom. So basically, the entire region of interest is registered instead of just 3 tattoos or skin marks alone. SGRT systems like AlignRT and Catalyst are already in clinical use, helping reduce setup error and even it also supports DIBH, which we'll get into next. So in this picture, we can see, so there's the pink part is the reference image, reference surface of the patient, which is generated through the CT. And then the gray area is the region of interest, which will be monitored. To give a better clarity in this picture, which is of the left leg, we can see on the left picture, we can see the green part is the reference image and the purple one is the displacement. And then positional corrections are applied, which can be seen on the right image on the right side, where the purple part, which is the displacement, is a lot less than the other one. Now, deep inspiration breath hold, or DIBH, is a technique where the patient takes a deep breath and holds it, and it physically shifts the heart away from the treatment field. Now, this reduces radiation exposure, especially in left-sided breast cancer. In DIBH integrated with SGRT, surface-guided radiotherapy allows us to monitor the patient's surface in real time, ensuring they hold the breath at the right level. And if they drift out of the present rate, the treatment can automatically halt or pause. And this integration makes DIBH much more accurate and safe. So even in this picture, again, the surface map is created of the patient, which is live, and the red spot here is the breathing spot, which will be monitored. And on the breathing curve, you can see that the beam is turned on only when the patient holds the breath at the right position, at the right level, sorry. So SGRT provides multiple clinical and patient-centered benefits. Studies consistently show it improves setup accuracy and reproducibility across sessions, which is crucial in treatments like hypofractionated breast radiotherapy. One major benefit is that it doesn't rely on tattoos or skin markings, making experience much more comfortable for the patient. It is non-invasive and doesn't use any ionizing radiation. The system also offers real-time postural tracking with a large field of view, giving a more holistic positional verification. It also reduces radiation dose to nearby organs with the integration with DIBH. It shortens setup time, minimizes the additional imaging, and also automated treatment interruption is also possible when the patient moves out of the preset tolerance. So given these potential benefits, the aim of my study is to evaluate the accuracy of SGRT in patient positioning also to study the SGRT in deep inspiration breath hold and how it helps with the treatment. And I would also like to identify the current limitations in SGRT, which is used in clinical practice right now. To achieve this, I will conduct a systematic literature review. I'll start with database search using keywords and Boolean operators. I'll be using databases such as PubMed, Scopus, and Science Direct. The next step would be the refining, for which I first remove all the duplicates and only include the last on papers published in the last 10 years. Also based on relevancy by doing a title and abstract review. And also have like inclusion, exclusion criteria for a structured screening. And then I'll also like to classify the papers so that it's a bit more organized and easier for me to extract the data. After the initial screening process, this review will primarily focus on clinical observational studies that assess the role of SGRT in breast cancer. Now, the key focus areas include the measuring positional accuracy using SGRT versus traditional tattoo-based and IGRT. And also inspiration breath hold when guided by SGRT. For data extraction, I'll compare the results across studies using IGRT as the reference. The main parameter of interest are translational displacements, which include lateral, longitudinal, and vertical, and also rotational errors, pitch, roll, and yaw. And also 3D vector shifts used for patient repositioning. The comparative evaluation will involve a quantitative analysis of the reported displacements across various patient setups, and also a qualitative analysis of DIBH, considering aspects such as patient comfortability, compliance, session-to-session reproducibility, etc., and identify the limitations. Now, as for the expected outcomes, I expect to through the study, I expect to prove that SGRT enhances setup accuracy and also improves the workflow of the whole process. And SGRT enabled DIBH benefits, which reduces heart dose, and also validate across institutions. Kind of validate the whole result across institutions. I also expect limitations, which from my preliminary study, which includes need for staff training and workflow adjustment, which can be quite hard since it's a new technology. Some papers report surface shadowing and visibility issues due to the chin and arms. Another problem is that it doesn't completely cannot be IGRT cannot be avoided completely. It still relies on IGRT, just that we can reduce the reliance on IGRT, maybe the frequency of IGRT. From the preliminary study that I did go through quite a few papers, and this is a result that I got. Now it is almost all the research papers that I went through, SGRT is proven to be much better than tattoo-based setup. So yeah, I expect to add on to this. To conclude, this proposal outlines a structured plan to evaluate the role of SGRT in breast cancer radiotherapy, and by examining positional accuracy, breath hold techniques, clinical workflows, and limitations, the review aims to generate insights to support its effectiveness and support its effectiveness. Thank you.
Thanks. When you're talking about the ground truth, are you talking about the 3D alignment of the anatomy underneath?
Yeah.
The target alignment?
Yeah. Image, using X-rays. Yeah. So that it's used to compare because SGRT, as much accurate as it is, it's not completely reliable just on SGRT. We still need occasional IGRT as well so far, like as of now. So IGRT is used as a ground truth to compare how effective SGRT is.
Is there generally a one-to-one relationship between the surface and the anatomy underneath, or does the anatomy underneath sometimes shift relative to the surface?
It can shift. It doesn't have a clear ending, but then in the end, for radiation therapy, we need like IGRT is not IGRT alone cannot give a clear understanding of where the of the whole the treatment. So surface guidance is also it kind of aids to the accurate position. Right? Yeah.
Question.
Is Roger, you have a question. Before Roger, you ask a question. I just need to add to that.
Yes, Nakshatra, thanks. That was a very nice talk. Thank you. Very, very clearly presented. Look, I just have one quick question. One of the outcomes that you're hoping for is improved clinical workflow efficiency. Can you just very briefly sketch how you're actually going to assess that metric? Are you going to rely on the assessments of others and bring them all together in some kind of average, or are you going to apply your own metric to the descriptions of the published studies?
Yeah, good question. So as for the workflow efficiency, a lot of the papers that I went through actually measured the time as well for the whole setup procedure and compared it with compared SGRT's procedure with tattoo-based one. So and the studies report that the SGRT one takes a lot less time compared to the tattoo-based one. So I would like to include a time evaluation as well in my study. Does that answer your question?
Yes, thank you.
I should add that Nakshatra doing 4 units of research. She is Master of Medical Physics, and her project is literature review. So just want to make it clear for the assessments, this is 4 units of research, and next semester, Nakshatra is supposed to finish the research and also radiotherapy unit. She hasn't done radiotherapy yet. So this information just is explaining to us is just she learned herself, not through the course yet. So that's just to clarify.
Thanks. One just quick question. Have you kind of thought about how you're going to collate the data from all of the studies that you're finding in your systematic search? Because I guess you can kind of use the averages that they've presented, or you can use individual patient data from those studies. And is that something that you need to do you think, potentially?
So most of the clinical observational studies already had presented a set of data. Mostly, almost all of them, if I remember it right, does have a translational displacement and also calculates the vector correction. So I'm just trying to.
Is that at the level of the study though, or the level of individual patients? I guess what I'm asking is, do you think you'll need individual patient data from those studies to draw some conclusions?
I'm not 100% sure that I understand it. Could you repeat that?
So the studies that you're looking at in the literature, they're
Yeah.
going to be presenting, averages, right?
Yeah.
But of course, those averages are just reflective of some underlying patient population.
Uh-huh.
And sometimes with systematic reviews and meta-analyses, you can actually get access to that individual patient data and use that instead for the analysis that you want to conduct, right? When you sort of bring everything together. So my question is, do you think you need to do that, or is it sufficient just to have the averages from the papers?
I think it's sufficient enough to get the justify the average, because it is quite a big, there are a lot of papers on it. So, and I think there's enough data on it, but yeah, I think I'll look into it. I'm not sure.
Yeah. How many papers did you identify? Just quickly.
As for clinical, approximately, just the clinical observation data, I think I found around 20 papers with proper results, and then a few simulations without patient data and some other papers.
Surface-Guided Radiotherapy is a new technique. So,
yeah, I mean, still 20 is not bad.
That's not bad, but so I'm pretty sure if you check next semester, even middle of semester, you can get more information.
All right. Thank you.
Thanks so much.